Perfect. Yeah, so like I said, thank you for the introduction. Yeah, my name's Tyler. As you can see here from my presentation and from the material sent out ahead of time, the case and the interaction that I will be exploring here today is related to duloxetine and CYP1A2 and how smoking status can impact um, use of duloxetine. There, if my clicker will work here. Do not have any disclosures to report today. So first off, I'd like to start introducing the case in a very common report that many of us have probably seen, especially those of us that work in clinically with pharmacogenomics and GeneSight, but many other reports might highlight duloxetine in the report. Calling out here with the GeneSight report is sample report they have on their website. What they've done in the last couple years, from my understanding, is that they have started to separate and present results in two different manners for both antidepressants and antipsychotics. They will categorize their binned or classified, red, yellow, and green medicines, calling out whether the patient is a smoker or non-smoker, that they will have different classification of those interactions. So I've kind of got shown here my first two slides. You can see duloxetine, if they're non-smoker, they might, depending on what the genetic result is, they might classify as use as directed or a significant interaction. While duloxetine is noted within CPIC and DPWG, FDA labeling, and some other drug labels, as having some potential pharmacogenomic implications. That is primarily addressing CYP2D6, and at this point, really across many of those different guidelines or FD or labeling, they really kind of note that there's no real clinically relevant interaction with CYP2D6 at this point, or at least a lack of data to support any any clinical recommendations. And so this interaction, although we don't know, GeneSight's algorithm and what goes into their decision making specifically, we know is a potential association with CYP1A2 smoking status, that likely is, the cause for the difference here with how they present the information. So I guess I kind of use that as an intro, and then we'll kind of get into the rest of the information here and kind of revisit that throughout our case. The case that we will be dealing with today is a patient with fibromyalgia. And so I won't get into too much on the specifics here and too into the weeds, but just kind of want to briefly refresh diagnosis and common treatments for fibromyalgia. It can be a very frustrating journey for patients to arrive at a diagnosis. Historically, it's been kind of classified as called a rule-out diagnosis, although now there are guidelines that have diagnosis criteria to help with making that diagnosis. But very commonly, patients are presenting with a combination of either chronic widespread musculoskeletal pain and or persistent fatigue and sleep disturbances. There are a number of other symptoms that patients may present with, but those are really the primary symptoms that patients have. Of those that I have listed as some common other symptoms, I see, kind of my practice, I think most commonly I hear patients complaining of having that like fibrofog, memory impairment, and then really a high incidence of comorbid depression or anxiety. So when we look at treatment, there's kind of a lot of variability depending on the guideline, what they recommend. Like I said, there's a lot of variability, but there's also a lot of common themes. Number one, we should really be making sure that patients are focusing on potential non-pharmacological interventions, which number one is just making sure patients are educated. They understand what the disease, or what the condition is, potential symptoms, and how physical activity and psychological therapy can be beneficial in helping improve symptoms. So as always, that goes for anything, as far as a pharmacist, and many of us here might be pharmacists, that, we're always focused on medicines, but making sure that patients are aware of those non-pharmacological approaches to managing that. As far as medications go, I have highlighted the most common meds that are commonly utilized. Again, there's a lot of variability with different guidelines. There's really no kind of set stepwise like A to B approach that we should take to treating fibromyalgia. And with medicines, it's really going to kind of depend on what are the patient's, kind of comorbid disease states or what sort of symptoms are they presenting. For somebody that maybe has more paresthesias, gabapentin and pregabalin might be more likely to be beneficial. Um, you know, Considering or SNRIs such as duloxetine might be more beneficial than alternatives. So it's really kind of dependent on the patient and their presentation. But between the tricyclics, SNRIs, and gabapentin and pregabalin, those are really most common medicines. Some other atypical or less commonly used meds, such as low-dose naltrexone or some anti-epileptics, might also be considered. Of note, and very important to take into account with fibromyalgia, is that we really should be encouraging the avoidance of long-term use of opioids. Although I commonly see in the patients that I see, hey, this is really the only medicine, or I've had really good benefit with opioids. There's some data to support that use of opioids for fibromyalgia has the potential to increase pain sensitization and actually increase pain symptoms associated with fibromyalgia in the long term. I have noted here that tramadol, because of the SNRI activity, might have some more benefits, relative to some other opioids. But again, in general, we should be, encouraging both patients and providers to be avoiding long-term use of those. And then although NSAIDs and other anti-inflammatories might be utilized for pain, at this point, there's really no proven benefit for long-term use of those, specifically for fibromyalgia-associated pain. So let's talk a little bit more about the medication of interest today, duloxetine. As I had highlighted on the first page, that is one of the common serotonin norepinephrine reuptake inhibitors that is commonly prescribed for fibromyalgia. Important to note, the effect of the medicine for pain has commonly been believed to be related to the norepinephrine transporter effect of the medicine. And so when we look at the relative affinity, duloxetine has stronger affinity for that norepinephrine transporter than does venlafaxine, and why it's commonly utilized. Sorry, I apologize. I'm bumping the button here on my headset. Uh, why duloxetine is commonly used for pain indications, including fibromyalgia, in favor of venlafaxine. But you can see milnacipran also has a strong affinity, in fact, stronger than duloxetine for that norepinephrine transporter. Important also to highlight that the inhibition is sequential. So at lower doses, we're going to see greater inhibitory effects effect at the serotonin transporter. And then as we get to higher doses, where we're going to see that blockade at the norepinephrine transporter. And so although there's a varying, kind of a wide range of dosing range for both indications, why we generally can see a lower effective potential dosing with antidepressants or for antidepressant dosing, whereas we might need higher doses for pain management. Metabolism of duloxetine is primarily hepatic. Specifically, you can see here in the PharmGKB pathway via CYP2D6 and CYP1A2. Although there's two different pathways of metabolism, at this point, it is believed that really all of the downstream metabolites are inactive, and so really our pharmacological activity from the medicine is really coming from the parent duloxetine. In excuse me, in our PK studies that are cited within the drug label, kind of comparing the effects of different inhibitors. So fluvoxamine being a strong CYP1A2 inhibitor, and then paroxetine being a strong CYP2D6 inhibitor. We can see some pretty significant increase in total exposure. So with paroxetine, an increased AUC of about 60%, whereas with fluvoxamine, that is a six-fold increase. So that really kind of highlights the significance of those two genes and why it's believed that CYP1A2 likely plays a larger role in the overall metabolism of Cymbalta, again, being that fluvoxamine there being the strong CYP1A2 inhibitor. Other PK parameters that were cited, just as kind of giving a little bit bigger context there, Cmax was increased by about a 2.5-fold difference, whereas half-life was increased about threefold. Again, that was with fluvoxamine administration. So let's talk a little bit here about the gene CYP1A2. With the conversion of a lot of our genes being transitioned over to PharmVar for standardization, CYP1A2 has now recently been transitioned to PharmVar. So as I'll kind of go through some of the information about the gene, if you guys are interested in wanting to learn more information, curious and wanting to dig a little bit deeper on CYP1A2, I would strongly encourage you to start with the PharmVar CYP1A2 gene information page. That was a really kind of a great resource and starting point for me here as I was kind of diving into the literature and trying to, with the case that we'll get to later today. The most common variant that is really noted in both research and in clinical pharmacogenomics is this negative 163C to A variant. Most commonly, that has been denoted as the star 1F variant, but with the recent transition to PharmVar, that has recently been classified as reclassified as a star 30 variant. So, when you're doing your lit review, and if you're doing that, or kind of looking at your pharmacogenomics reports, it's really still most commonly we're going to be reported as star 1F for the time being, but hopefully we'll see kind of a transition to that by different labs reporting that as a star 30. Many labs are focused on this negative 163C to A, but they may also assess for some other what are now retired upstream variants as part of this PharmVar standardization. But as it is reported in many reports, the other alleles that they might report based on those retired variants are essentially other star 1 suballeles. So star 1D, star 1M are some common ones. There's many others. And really many of those have either been retired due to not meeting the PharmVar standardization, or they are now classified as star 30 suballeles. And so this is really the most clinically relevant variant. Has a really high global frequency. You can see here it's about 2/3 global frequency of that variant. And why it's most relevant is because the association with increased expression of the gene in smokers. Important to highlight that this is related to cigarette smoking. It is related to the formation of polycyclic aromatic hydrocarbons with tobacco smoke. And so it is not directly related to nicotine use. So for people that might use nicotine, vape pens or other forms of just primary nicotine that is not that tobacco smoke, this association, increased expression of CYP1A2 has not been associated with nicotine. There is a lot of variability with how CYP1A2 and this negative 163C to A variant is denoted in different pharmacogenomic reports. GeneSight, for example, somebody that might be a heterozygote or homozygous, for this variant, they will actually report as two phenotypes. They'll call them normal if they're a non-smoker, and then ultra rapid if they're a smoker. There's, like I said, a lot of variability between different laboratories. Kind of see here, highly inducible. That's probably one of the more common ways that this result will be reported. So just making sure that you're aware when looking at reports, if you are using stuff, applying this stuff clinically, that we focus on what is the genotype, what are the actual variants tested for, and not just relying on that phenotype that is reported. With the transition to PharmVar, there was really a important thing highlighted within that gene information page that I have highlighted here, and want to make sure we have a chance to discuss and everybody is aware. There have recently been a number of different new haplotypes identified that include other non-synonymous SNPs in addition to the negative 163C to A variant. So for those that need a refresher or unfamiliar with genetic terms, the non-synonymous variant is describing a genetic variant that leads to an actual change in the amino acid chain. And so being as the variant is very commonly identified, it's really just that in a lot of clinical studies, it's just been that variant, or like I said, many other retired variants that have been assessed in studies. And so because there might be other haplotypes with other non-synonymous SNPs identified that are not known right now, when reports are highlighting this variant and calling them increased function, faster metabolism, highly inducible, that we're interpreting that result with caution because those other haplotypes in the functional status is really an unknown variable at this point. And again, just something I wanted to make sure we kind of highlight and make aware here as we kind of talk about the case today. Got just a couple studies that I want to highlight. I want to make sure we have enough time to get to the case, so don't want to spend too much time here. But a few studies I was able to, kind of find in my review here for this case is unfortunately not really a lot of really very minimal assessment of pharmacogenomic implications of the gene. So this first study, I think really key to point out was a pharmacokinetic assessment, a retrospective assessment of assessing steady state duloxetine concentrations, comparing smokers to non-smokers. They did exclude any co-medication with CYP inhibitors or inducers, but like I said, they did not assess CYP1A2 genotype or phenotype with this study. What they found is that in the smokers group, there was a significantly lower age compared to the non-smokers. So just something I think important to keep in mind when thinking about both this study as well as any of our patients that as metabolism tends to slow over time as people age, that can potentially impact the outcomes seen in this study. What they did identify in the study is that for the smokers group, again, in a naturalistic study, considered to kind of be a maintenance dose, that the smoking group had a median higher total dose compared to the non-smokers, which would suggest that those patients are having faster metabolism because they're needing higher doses for the same relative effect. And that was a significant difference. But I think even more meaningful is that when they accounted for the serum concentrations in addition to what the patients were taking, that there was an even bigger effect. And that when we look at the concentration to dose ratio, those in the smoker group had about half a statistically significant lower total concentration to dose ratio. Again, supporting the idea that smoking status is increasing metabolism of duloxetine, but again, not a clear assessment of how CYP1A2 is actually, playing a role in that relationship. A couple other studies here without getting too much into details. There was another PK study and then a meta-analysis of 5 other studies done prior to this, that first study I just reviewed, but they really kind of showed a similar trend that the smoker group in general tend to have lower serum concentrations and a lower concentration to dose ratio. Again, just a handful more studies here supporting that association that smoking status leads to lower exposure to duloxetine. I found a recent study assessing clinical impacts or attempting to assess clinical impacts of both CYP2D6 and CYP1A2 on response to duloxetine. I won't get into too much details on this study because from my perspective, there was a lot of limitations and a lot of question marks I had in reviewing the study. You can see they only assessed really a small number of variants for CYP2D6. Ultimately, though, and this was not a PK assessment, again, just trying to assess clinical outcomes, response, and side effects with duloxetine. They did not see any difference based on CYP1A2 and the variants that were tested for. However, of note, of the 100 patients, there were 27 that were smokers, and they did not assess or differentiate within those CYP1A2 results whether or not patients were smokers or not. And I think, we look at the context of the previous studies, that's I think a big limitation of this study. So if anybody has otherwise dug into the literature and seen other studies, I'd really appreciate after today if you'd like to forward me anything that you found. But those were kind of the key studies that I highlighted as part of my prep for this case. So it kind of brings us back then to the GeneSight report. And, with the lack of CPIC guidelines, myself and I know many others have concerns with how a lot of different reports might categorize non-CPIC medications, especially when we look at the lack of pharmacogenomic data specifically related to this interaction. I think it's clear that smoking status certainly has a significant impact on exposure, but as I kind of highlighted here, there's a lot of unknowns and just something to kind of think about as I'm always questioning when I look at these reports and how do I apply them clinically. Um, there's a lot, I think, a lot to take into account here. So, um, questions, thoughts at all here?